everyone, my name is Abigail Mize. I am a registered cardiac and vascular sonographer with a special interest in peripheral artery intervention and research. I am going to show you a case today that really highlights the benefit of vascular ultrasound. Throughout my career, I've had the opportunity to work in a cath lab as well as a dedicated critical limb ischemia intervention lab at an outpatient facility, and I've really learned that ultrasound can truly be used for more than we think it can, certainly more than we learn in school, and I'm very excited to highlight that for you all today. I'd like to thank the meeting organizers for allowing me to show you all this case today. I've had the privilege of attending the FACES conference. I love how ultrasound driven it is. So thank you to Dr. LeSar, to Tracy, LeSar, and everybody at VIC for inviting me back this year. I'm sorry I can't join you all in person, but please, if you have any questions, I will have my contact information at the end. You are welcome to reach out to me at any time. So this case was a 66-year-old male. He presented to our clinic with really severe rest pain of his left leg. His foot was truly that purpley rubor, sort of that advanced stage PAD. He had all the pretty typical risk factors, high blood pressure, hyperlipidemia, diabetes, and a significant history of PAD. Most importantly here was the history of fem-fem bypass in 2008, and he's had several previous failed endovascular interventions. He presented to our office because he was told by his previous provider that there wasn't much else they could do for him, and he was continuing to experience worsening claudication that had now progressed to rest pain of his left foot. An ultrasound was performed on a diagnostic basis that demonstrated the SFA was occluded at the ostium, and he had very low flow in those tibials to his foot. So this is a really nice picture here of the ostium of the SFA. You can see the occlusion starts here, and then this is the reconstitution sort of in that very distal SFA. This is marked as proximal pop, so just into that P1 segment. Given the ultrasound images, so this is just an image of the report, again reiterating that the SFA appears to be occluded at the ostium. Important to note here, though, that all three tibial arteries were noted to be patent, even though they were monophasic. So the first question that the physician I would be working with in the procedure room would ask me is, well, can we go antegrade? Anytime you have an SFA occlusion, if there is enough runway just beyond the bifurcation of the common femoral into the SFA, an antegrade approach really gives you better pushability. It allows you to better penetrate that occlusion to get into the native vessel. We would evaluate that with extravascular ultrasound, mapping of the potential access sites, looking at the common femoral artery to see if there is that, quote, runway, ideally in order to, enough runway to place a sheath that's, about 7 centimeters in length. This didn't apply here because this patient did have a known fem-fem bypass. So that, on top of the occluded SFA, made it very, very difficult for us to be able to do anything in a traditional manner in the groin. So the second question then is, what would the access approach be for this patient? Given the caps that were noted on the duplex ultrasound and the shape of them, you have a concave cap proximally and a convex cap distally if you are coming in from above. The physicians I worked with helped develop the CTOP classification. They followed it very closely. So given the CTOP morphology, having some sort of retrograde access as well as an antegrade access really would be the best crossing technique. Now, given that the groin access was going to be difficult, we opted to begin with a tibial approach, knowing that later on in the procedure, we would have the potential to use what we would call an assisted femoral access, and I'll discuss what that means later on. So the first thing I did was mapped the tibial arteries for potential access sites. We knew that based on the duplex ultrasound that all three tibial arteries were patent. In that instance, the posterior tibial artery is your best option for pedal access if you're using it for crossing. It's a straight shot up into the TPT and into the popliteal. It's very superficial at the ankle. It's easily visualized. So we had to make sure that the vessel was large enough to accommodate a potential interventional sheath, 5 or a 6 French. In this case, this artery was 3.4 millimeters, which is plenty large enough to accommodate a sheath. We had to look at the calcification. This affects your decision to puncture or not, as well as how easily you can close that tibial artery. This artery happened to have just a little bit of calcification, but nothing significant. If we're utilizing a TAMI approach, which is where you would treat the entire leg from the pedal axis only, we do need to accommodate that sheath. And again, so as we mentioned earlier, this one is about 3.4 millimeters. A 5 French sheath is usually about 2 to 2.5 millimeters, so should be plenty large enough for that. And then if you are using your tibial axis only, we want to make sure that we have other arteries that are open to the foot. We want to try to avoid puncturing a single tibial runoff, just in case that's the only runoff that patient has. We don't want to risk compromising it. And in this case, we knew the patient had 3-vessel runoff. So we chose to access the posterior tibial artery. So here you can see the wire is very easily gliding right through the artery. I couldn't even keep up with the physician because it was advancing so easily. So we knew he was luminal. We knew he was in a good position. Angiograms from the tibial artery approach are a little bit difficult, but this first angiogram does show kind of the hint of those 3 tibial arteries, so we confirm they're still patent. And then once we got to the popliteal, it's very, very difficult to push contrast all the way up the leg. But this image did well define the sort of the reconstitution all the way at the bottom of the screen there, just before it crosses the bone. So it was just in that P1 segment. The majority of our SFA was able to be crossed under ultrasound from the retrograde axis, which is great. This is a common technique that our physicians used. We are following the wire or the catheter under the ultrasound in live time, ensuring that the wire and catheter are remaining in the lumen, prevents subintimal crossing, and it prevents you from having to pull everything back and kind of redo. It saves you time, contrast, and radiation. Heavy resistance, though, was encountered at that ostium, which we sort of anticipated based on the shape of the cap. There's the catheter sort of struggling to really get from the ostium of the SFA, which begins here. This is the profunda, trying to get into this common femoral artery. So we decided to proceed with what we called assisted femoral access. So assisted femoral access means we're probably not going to use that femoral access for any sort of therapy delivery. Because this groin was so compromised from the FemFem and from the occlusion in the SFA, we knew that this was just going to be needed for assistance in getting into the true lumen across that osteal occlusion. So we used a 3 French micropuncture sheath. That's a very small sheath. And a very stiff CTO wire was used to sort of probe and interrogate that proximal cap, and we were able to advance to the retrograde catheter. Once the wire sort of followed that catheter down, we knew that we were in a good spot. We were in good shape to then go ahead and proceed with therapy. Before we did that, though, we always double-check luminal placement. So this is a short axis view. On ultrasound, I was running my probe down the length of the thigh, evaluating the SFA to make sure that here's the vessel. We could see our wire and our catheter. The wire is from above, the catheter from below. Both are remaining within the walls of the artery. That tells us that we are very confident that the crossing was done in an intimal manner and there was no subintimal segments. We then did IVUS. Our physicians are big IVUS users. I love IVUS. It's all ultrasound, so it's very easy, excuse me, for an ultrasound tech to sort of interpret this image. So you're looking at cross-sectional images of the artery, but from the inside instead of the outside. So this catheter, this big orange dot right in the center, that is your catheter. You can see the artery walls here. You can see this thickening gray material. That's where this catheter starts to advance into the CTO. But we see that the catheter remains within the artery. Maybe a slight subintimal crossing in this segment here, but otherwise, this is a really, really nice looking crossing of this long segment SFA CTO. And I will also point out here that we do have a lot of sort of that grayish material, but we also have some of the brighter material that's suggestive of sort of this multifaceted fibrotic, maybe some calcified, and also some softer plaque. So because of the soft plaque and sort of the mixed morphology, the physician that I was working with at the time opted to do some atherectomy to prepare the vessel. Because this was such a long occlusion, he wasn't convinced that balloon angioplasty alone would do it for this patient. So he did use atherectomy along the length of the occlusion of the SFA. You can see the catheters there moving kind of very slowly, which is what's recommended by the manufacturer to really allow that catheter to sort of penetrate and sort of ablate. This is a laser catheter, sort of ablate that plaque across up against the wall. And then after the atherectomy was completed, the angiogram was again repeated, and you can see there's a bit of a dissection in that proximal segment. So we proceeded with balloon angioplasty to hopefully sort of tack that up. Long balloon angioplasty here, again, the entire SFA was occluded, so we really want to make sure that we're opening up this artery as much as we can. However, on repeat angiogram, there was still a bit of a hazy spot, and that sort of corresponded to where that ostial occlusion was and where we had difficulty crossing. So don't forget here, though, that we do have retrograde access. So the physician decided to proceed with a stent at the ostium just to kind of tack that segment up, make sure that we could give this patient the best chance at long-term patency that we could. This is my favorite technique to show people on ultrasound for interventional procedures. This is retrograde stent placement in the ostium of the SFA. So this first video here that you see is the physician just deploying that first stent stress, so just kind of flowering the stent open and pulling the stent into the ostium of the SFA to really truly seat it away from the bifurcation and to not impede flow into the profundifemoral artery. Once we verified that it was seated right in the ostium of the SFA and there was no flow disturbance, he then proceeded with deploying the rest of the length of the stent. So on final angiogram, that stent looks great. We've got nice clearing through the vessel. The rest of the SFA looks widely patent, does taper down a little bit in size, which we did see on the IVUS as well. But again, we maintained our 3-vessel runoff from the popliteal into the tibials. You see your AT, your perineal, and your PT are widely patent. And then this final angiogram here showing that the patient's foot flow has been restored. It looks like this patient has a complete pedal loop, so hopefully this intervention would have resolved the patient's rest pain. This patient did go on to do very well. Last I saw the patient was at his 3-month follow-up. He was doing well and was having no issues. So in conclusion, extravascular ultrasound or duplex ultrasound really plays a vital role in the treatment of these patients, not only from a diagnostic standpoint, but from an interventional standpoint as well. This was a very complex intervention with a long SFA CTO and limited access options given the patient's history. So we utilized that pre-procedure duplex for treatment planning, knowing that the patient had tibial runoff as well as the CTO cap shapes in planning that tibial access. The tibial access was then used to facilitate crossing and treatment. It was all ultrasound-guided CTO crossing, as I demonstrated earlier in that SFA, and then the retrograde stent deployment, which is a very advanced technique, but I love to show it because I think it really pushes the envelope for what people think ultrasound can be used for. So thank you very much for allowing me to show you all this case. I hope you enjoyed it. I hope you learned something. Please feel free to reach out to me if you have any questions. I also encourage you to check out the CLI Global Society if you are interested in learning more about critical limb ischemia. They've got lots of education opportunities, conference registration discounts. We also do a lot. I'm part of the education committee, and we do a lot of opportunities for not only physicians, but sonographers like yourselves, nurses, techs, and I encourage you to check that out and let me know if you have questions. Thank you all again for allowing me to show you this case. I hope you enjoyed it and enjoy the rest of your conference. Thanks.
I'm going to move forward with a little bit of my talk first, and then we will, when I get the word from our main vascular center, we'll move forward with the live case. So PAD, we're going to go just back a little bit. Loss of vessel elasticity is termed arteriosclerosis, and the buildup of that fatty, lipid-rich, gruel-like plaque is what we call atherosclerosis, and that's all the stuff that we see on our ultrasounds. This is generated by people who have problems with cigarette smoking or hypertension, anything that's going to interrupt the endothelial barrier, diabetes mellitus, hyperlipidemia, vitamin deficiencies, specifically folic acid deficiencies or the ability to process that, genetic misfortunes. It runs in the family. It can happen. Hardening of the arteries is what we call it. Sedentary lifestyle and gender, male being worse than female. So when we talk about atheroma, we develop these in our bodies. There are juvenile atheromas, sometimes they're very small with a little bit of cholesterol and lipid content, but as they become more mature, they become more fibrous. They can also move on to calcify, and so as our body tries to heal these things, the calcification process can be part of it. There's a problem, however, though, is that in that calcification, you can get a hemorrhage. And when you have a hemorrhage, you go from a grade 1 carotid stenosis to all of a sudden a grade 3. And it's because you have an unstable plaque that's occurred. So sometimes when I operate on these patients and I take out that atheroma in surgery, I call it a hemorrhagic plaque, and that's probably the most dangerous type because it could potentially rupture and or thrombose. And so the rupture of that plaque can be a little TIA happening in the carotid, or in the occlusion, it could be in your left main coronary artery, and that's what we call the widowmaker. So you could have a very 40% plaque that's very unstable, and the next thing you know, you are on the table getting a coronary stent. So PAD is a buildup of this plaque that interferes with oxygen and nutrient passage for cell survival. PAD worsens. As PAD worsens, the blood flow is reduced and even blocked completely. And PAD is not serious like heart disease since it only affects the legs. Is that true? False? False. Good, paying attention. This is great. PAD is 4 to 5 times more likely to cause MI or stroke. And so that process in our bodies is something that we have to figure out. Intermittent claudication is a very specific term. It's pain in the muscles of the legs when triggered by activity. It's a walk, rest, walk cycle. Limb-threatening ischemia is when the blood flow is not enough at rest in either acute or chronic situation, causing rest pain, where you're having pain in the foot, or even tissue loss like ulcers or gangrene. So we have often get, just checking in right now, okay. We are often presented with multiple different forms of disease for these patients. This gentleman right here was a farmer. It took him 3 months to figure out that he actually has arterial disease. He kept asking the doctor, why is my foot red? Why am I getting sunburn on my foot? I mean, you could see his farmer's tan right above his boots, and he couldn't quite figure that out. But ultimately, he had to have that repaired. Sometimes patients just don't know what to do. This patient had her toe turned black, and she just ignored it. Maybe it'll go away. Maybe it'll heal up, and it didn't, and she eventually infarcted the whole forefoot. And so we could actually clean out the arteries at that time, and everything would reocclude almost immediately because she had no capillary level flow. This patient, as they present with PAD, you can tell he's been seen by a provider, a physician, somebody medical, because they're painting betadine on it, because that's going to make it better. Well, that's not the natural history of this. The toe doesn't just fall off. Ask any of the podiatrists, this is a surgical issue. You have to remove that toe because there's tendons and there's bones. And so the natural history would be for that to infect and have an abscess and then explode through the foot and then cause sepsis and death. And so we can't just paint it with betadine. You actually have to fix these problems. This is a young lady, 30-ish-year-old African-American female who in that left panel is status post 6 weeks after revascularization to her foot. And she's going to lose her toes. I mean, they're already dead. I can't fix that. But we can save her foot with a transmetatarsal amputation. Now, unfortunately for her, she is also end-stage renal disease. And so she's seen 3 times a week, in with nurses and doctors and in a clinic setting. She infarcted her other foot, and nobody said anything about it. She didn't say anything about it. I took the sheet down, and I'm like, oh, wow, we have a new problem. It's predominantly because her sugar level is 500 on an average basis. So before I jump into clinical assessment, I think we are ready now for the live case. Is that correct? which are okay, so I got more time. Good, I'm going to keep going. So when we do a clinical assessment, we have a couple different classification schemes, Fontaine, Rutherford, depending on which part of the country you're from. Rutherford tends to be the more common. Think of claudication as Rutherford 1, 2, 3, 3 being someone can't walk the length of a football field and back. So if you can't do that, you have to stop. That's Rutherford class 3. And thank you. And we probably need to do something about that to fix their exercise tolerance. Now, Rutherford 4 is when you have ischemic rest pain. Rutherford 5 is when you have tissue loss. So this is 4, this is 5, you have some tissue loss. And 6 is you're going to lose part of your foot to save your leg. There's no way about this. There's major tissue loss, and that's a surgical issue. As far as how a critical limb specialist thinks about things, we use the concept called angiosome. An angiosome is the foot is divided into multiple different areas of flow with different arteries feeding that different area. So an angiosome is an anatomic unit of tissue fed by a source artery. There are 6 angiosomes within the foot. Targeted therapy of the artery to the ischemic wound. If you have a wound on the bottom of the foot, I know I need to be in the posterior circulation, the lateral plantar artery, more than likely. This can maximize ulcer and wound healing. And sometimes there's isolated arterial perfusion. If you don't fix that one artery, then you are not able to be, you're not able to heal that region of the foot. And so this is a cadaveric view of the posterior circulation. You have in the pink, the lateral plantar artery territory. You have the medial plantar artery that is in the kind of the instep of the foot, and then the calcaneal branches. Sometimes that medial plantar actually extends onto the great toe. So if you have a lesion on the tip of the toe, sometimes it's actually the posterior circulation that we need to fix for these patients. All right, I think they are still working on their on the case, so we're going to be pulled in when you tell me. So subintimal angioplasty is one of the early ways that we fixed arteries from the inside. Before this concept, we did surgery, external surgery. We did a bypass from one point to the other point. We opened an artery, do an endarterectomy, clean out that artery. But once we had wires and balloons and sheaths that we could actually work in these arteries, then we can do something called subintimal angioplasty. Now, the subintima is that region that is external to that plaque. And so we can actually get a little wire on the external side, just like we would at surgery, where we can carve out the plaque. We can carve out the plaque. We can then create the channel for our interventional care. Before we get to that exciting part, we're going to try to jump into the live case and learn about how we deal with PAD.
Hey. Hello, everybody.
Hey, Will.
Thanks for having me. We are making progress. We have a gentleman here who's relatively young, who has really severe peripheral arterial disease, type 1 diabetic, long-time smoker. He has a functional occlusion. So you can see a fairly robust profunda femoris coming over that has probably become more robust since his SFA, which you can see in the middle of the screen has essentially become 100% occluded. I'm going to move the screen here down, take another picture. You can kind of see how bad this is. So the mid-superficial femoral artery, patient's 100% occluded, and it comes back there at the distal superficial femoral artery there. So what we're going to do is try and get across it and stay within the true lumen. Open me up an O&A IVUS at some point, please. Live. And so we're going to come up from the bottom, come from the top. I'm going to confuse Aaron as much as possible.
We'll just check to make sure that you can hear us okay.
Yeah, can you hear me?
Yep, you're great. Please.
Great.
Please go ahead.
So I'd like to thank Immertech for kind of helping us out with this and providing the audio feed into the system, into the conference, and the video feed. So as you can see, I'm coming up from the tibial. I've got access in the contralateral common femoral artery coming up and over. Pick the right side to look at the left side sometimes. And then I've got a catheter coming up from the tibial artery as well to try and cross this lesion. Go ahead, live. So I've got a Truma wire going through. This is called a Glide Advantage, and a Truma Navicross catheter, which is an 035 catheter, and attempts to cross this. And you know, it's better to be lucky than good, because it looks like the way that wire is advancing up, I think I've cracked Pater. So let's see if we're in the true lumen. DSA. So thus far, it kind of looks like I might be in the true lumen. We'll see. Live. We're going to open.
Practice does make perfect, Will. This is good.
Yeah, I might not be. I might actually be in a subintimal space. So since that's the case, what I'm going to do is come from above the catheter. Live. So I'm coming from above with the catheter to kind of feed into something that I know is the true lumen. This is a 035 system from above. Give me steeper LAO, please.
So we were just going through the didactic portion of subintimal angioplasty and transluminal angioplasty. And so if you can
DSA?
If you can stay within the true lumen of that vessel, then we have more options of therapy. There's different things.
That's 100% correct. Why?
And sometimes if you get outside of that plaque area, we can be in that subintimal space and trying to get back to that main lumen. Looks like they're...
So our catheters are touching right here. Can I get a 300 018 glide advantage, please?
So this is why I told my wife when we had our children that she would complain about Nintendo with the kids wanting to play this all the time.
Yes, please.
And it's like, no, let them play Nintendo, because that's what Dr. Harris is doing.
That's exactly right.
He's doing
so
this.
What I have here is I've got an 018 catheter, or I've got an 035 catheter, essentially kissing an 035 catheter. And I'm going to try and feed the wire in from one side to the other.
Will, can you magnify that a little bit?
Yeah, hold on, Aaron's magnifying it right now.
Love it.
So you can see the catheters are essentially touching each other right now, coming from below and coming from above. What we're going to do is, or at least what we're going to try and do, is feed this wire in from the bottom to the top. Wendy's having technical difficulty with the wire. I'm sorry. Live. The catheter.
You shouldn't make fun of your staff, Will.
I know.
That's unhelpful.
Well, I mean, they make fun of me, so I gotta give it back to them.
It's fair. So he is working with that little wire, super magnified. It looks like you can see it, like it was just so easy to fall in there. But that wire is, very, very small, size of a needle, and he's trying to connect those two catheters. And one of the reasons why he's doing that, and I'm talking so he can focus and do what he's supposed to do, is we're trying to stay within a true lumen idea. So we want to be, he knows he's in the true lumen from below. He came in the true lumen from above, trying to cross that lesion that's occluded, and now working through that process to connect the two. So we're going to give him a few minutes to do this and watch him.
Yeah, you watch me just kind of struggle a little bit.
And that's part of this. This can be quick or it can be slow, and but it's the results.
And remember, we're viewing this in a 2D. We're taking a 2D vision of this in a 3D space, and so our catheters are kind of all over the place. You're never sure if you're really on top of each other or not. So sometimes we'll rotate our C-arm different ways to give us a better perspective on things. You can see there, my wire's really not touching the other catheter, so I may like advance this down, may move one up and down just to kind of get closer.
So in our lab, the vascular surgeons do most of the ultrasound in the operating room. And so we don't have technicians, ultrasound techs actually in the operating room to help us. Now, Abigail was talking about her job as she worked a lot with cardiology, and they need all the kind of help they could get. So, but I also would love to have an Abigail in my world. So I'm just saying that out loud, to be able to see exactly where those two catheters are in real time may be very helpful in establishing that connection. Sometimes this is, this technique does take a little bit of time. We're going to give Will, a couple more minutes, and then probably jump out and give the lecture while he's still working. But we're definitely going to see what he does once he makes that connection. And
I have a 300B18, please.
Will, how long was that lesion that you're actually trying to cross right now?
It's about probably 20 centimeters or so. The whole proximal superficial femoral artery is severely diseased, but the actual chronic total occlusion itself is probably 10 or 15 centimeters. Mm-hmm. So I'm going to try a different approach. You come from above, because I know I'm true lumen from up here. So I'm going to run a wire down from the top.
Did that just fall in?
No.
Did you just pull it back out?
No.
Right.
It looked like it. I thought I was that good.
Yeah. But you're not.
No, thanks for reminding me. But that's it.
But that looks like it. That's it.
Yeah.
Okay.
So,
I take it back.
Yeah.
You're that good.
All right. So now that we're into the system, now that we know we're true lumen from one way versus another, I kind of want to look at the plaque morphology. And I think that's really, really important when you're deciding how to treat a lesion like this. And so what we're going to do is run a catheter down. I have to open this up. We're gonna floss these wires.
So what he's
by
done,
flossing, it means I've got a wire coming in from the bottom and a wire coming in from the top. So you can see here, my wires come in from the bottom. Whoa! Sometimes the quarters run out in the anesthesia machine.
Patient's alive. That's good.
Yes, exactly. Get a hemostone.
Yeah, trying to kick the doctor.
Exactly. So we pull the wire out from below. Now this is where ultrasound really comes into play, the intravascular type. And so we're going to run a catheter into the vessel and take a look. And number one, it'll ensure that we're in the true lumen space. And number two, it'll kind of look at our plaque morphology. Plaque morphology means the kind of disease that is in the vessel. If it's really heavily calcified, like stalactites and stalagmites, please. Or if it's really soft type plaque. And that kind of makes us determine how we're best going to treat this. I'm torturing you by making
Yes, I know.
load it over a wet noodle.
But I did it.
You did a great job. All right, so here we've got this catheter. This is an intravascular ultrasound catheter manufactured by Philips. And so you can see on the IVUS screen that's projected on your screen in the audience, at least Tate assures me that's the case. We're in the popliteal artery right now, and see it's a pretty healthy, robust vessel. Oops, we just lost our, oh, there it is. So the black area in the middle is the blood flow, and the outer ring is the vessel, and that's relatively healthy vessel wall right there. You can see the different layers of the vessel. But you start to get up, and you start to see the soft plaque form on the walls. And then we'll go up even a little bit higher, and there we're into the occlusion. So we're true lumen within the occlusion. It's a very soft plaque. It's very soft plaque morphology throughout. Going up, kind of almost a We are true lumen throughout the entire thing. Going up, which is good. Do you think we can get a laser into this room, or is that going to be too much?
Aaron, do you think we can get laser in here?
Okay, I think this plaque is very amenable to using a laser type device. And you can see there's a, can you record? We're up to the common femoral artery right here. So this is essentially a normal, healthy common femoral artery. You recording?
Recording.
There you go. So I was pulling the wire back accidentally. I was pulling the wire back accidentally.
Yeah.
So here's the superficial femoral artery. You can see that the size of the superficial femoral artery for this male is relatively small. Up here, it's a 4 to 5 millimeter vessel. He's not a large guy. Gets a little bit bigger, but you can see there's that soft plaque all the way through the vessel. We're kind of on the edge of the vessel, so we're not quite in the center of the vessel. That's okay. What we're going to do with the laser is blast through that and try and clear a lot of the debris inside the vessel with the laser. The laser is really safe to use kind of in this type of plaque morphology, this soft plaque, and where you're on the edge of the vessel. And like I said, the IVUS really guides our therapy in that respect.
Yeah, it looks like a very soft, mixed, heterogeneous plaque.
Stop recording. And so as you can see, we're now in the popliteal space right now. We're in the proximal popliteal. So that lesion really extended the length of the superficial femoral artery. Almost the whole superficial femoral artery is functionally occluded. So pretty long lesion. We're bringing in the Zamboni device, which is a laser. This thing used to be even bigger and heavier. Perfect. So it's not the most compact device, but for this lesion, I think it's probably the most efficacious. Would you agree, Chris?
Absolutely. So in this kind of situation, we have two kind of ways of thinking about it. One is an excisional device that will remove material, or the other one is a device that will break up material. So if it's extremely calcified, then we will want to try to break up that calcification. If it's more of a soft, mixed, heterogeneous type plaque, you have to remove it. You actually remove it from the body. So you can either ablate it with photoablation, laser ablation. We have other devices that can actually like scoop out the plaque and actually excise ribbons of that plaque throughout that lesion. And there's just different techniques to kind of to remove that plaque depending on really what the intravascular ultrasound shows us.
So this is so what we're doing is getting the old device used to have to warm up for 5 minutes. This device is kind of plug and play, and so we're plugging it in right now to get it going. I'll need a 5. It's not a very big vessel. I'll need a 5-200 cross stella once we're 5-200.
Thanks for help.
What do you mean?
Nothing now.
Yep. So right here, we're calibrating the laser. You guys all have to look away, otherwise you'll be blinded. No, it's just better. And so this laser is fed over this tiny wire. Sorry. 60-60. So we're going to advance it up to the lesion. You have wire? You do have wire? Okay, perfect. Fine. We're going to advance it up to that distal superficial femoral artery, and then we'll start treating. It's pretty noisy, so if you want to mute us, you're more than welcome to.
No, it's just fine, Will. So what he's doing is actually passing that laser along the length of that wire. And so this is not Star Wars. This is not shooting out a laser beam like you're going to zap the enemy far away. This wavelength of light will interact at about 1 millimeter from the tip of that laser catheter. So it has to touch the material, and then the photochemical ablation occurs, where the light energy will actually break the molecular bonds of that material and disintegrate it. And that's really what happens. And so as that plaque is being slowly disintegrated, we'll have to stop every now and then because it can cause some heat. Not often, but usually they can run for about 30 seconds and then have to stop. And then following the ablation, then we often use an angioplasty balloon to reinflate that area. Will, do you think this would be a good time to kind of jump back into lecture and let you finish the case? And
sure, give me 5 minutes, I'll get it all prepped out and set up for you.
Okay, that sounds perfect. You let us know when you are wanting to jump back in.
Yeah, absolutely.
All right, gentlemen, can we switch back over to the lecture? All right, so Dr. Harris is using catheters like these, wires, balloons to actually perform that transluminal angioplasty. This is where he was basically doing what we were showing here, where he's traveling through that very complex plaque. We can do that in different territories. This is an iliac artery transluminal intervention. The aorta coming at the top, right iliac is open, left is occluded. We come from below and we can pass a stent all the way to that level and then deploy that stent. And now we have a transluminal reconstruction of the iliac artery, giving flow back into that limb. Sometimes that's very calcified, and if it's very calcified, like in this case, we have to know where we are below and where we are from above, and you can kind of see where we're driving to. We don't want to, drive off-road up here. This is inside your abdomen. So you have to be very careful in subintimal dissections for iliac lesion. But once we get through establish that wire from above to below, then we can start doing therapy. We can balloon that slightly, we can lay a stent in and reconstruct that vessel. Superficial femoral artery, exactly what he is doing right now is that subintimal angioplasty. Here's an example of an occlusion on that left leg in the adductor region. And what we can do is create a wire that we pass into that subintimal plane. And as we kind of advance that wire, we can advance the catheter. And eventually we can get the catheter to that true lumen, and now we have the ability to treat it. And angioplasty is predominantly one of the most common things that we used to do when we first started this. When we first started endovascular therapy, because we didn't have a laser. We didn't have a lot of the different devices. Currently, in our lab, we have about 6 different devices that will remove plaque or break up plaque. And we just didn't have that at that time. So this was a subintimal angioplasty that prevented somebody to have a bypass operation. Can we push that down the road for patients? Absolutely. That's absolutely important. So here's transluminal dissection where we're working through arteries from above and below. And once we make those connections, then we can use angioplasty. So the natural, here's an example of a patient that has very complex disease. One of the things when we're working on treating these patients is obviously looking at the outcomes. Here he has a ischemic type foot. You can see the heel is actually blanching. The 5th and 4th toes are blanched, and he has multi-level occlusive disease. Our target when we're dealing with gangrene, non-healing wounds, is what we call the pedal arch. It is where all the digital arteries come from. And so as you're looking at his images right here, you see a medial plantar artery, but you see that the lateral plantar artery that runs on the bottom of the foot is actually occluded. The dorsal pedal is open, but it doesn't connect to that pedal arch. So if it doesn't connect to the arch, then angioplasty that won't help him. So we actually had to move into that lateral plantar artery, revascularize that with a atherectomy technique. And that one dealt with, it's called orbital atherectomy, which will deal with heavily calcified lesions. And so once we treat the inflow disease and treat the outflow disease, you can see that at 2 weeks we're starting to heal. You get a lot of desquamation of the skin. So when you're scanning these people, they're complaining their skin's peeling off. It's because they're growing skin again. That's really important. Their wounds can start to superficialize and actually start to close. And this is my favorite picture because he has a normal foot, even though he has an above-knee amputation on the other side. He would have been a bilateral amputee if he lost his leg. So it's important that you fight for these people. So this was a 69-year-old female. She had distal embolization of the first, second, and third toes at 6 months. She established a bilateral kissing stent at 12 months, significant history of smoking, and then palpable femoral but not popliteal or pedal pulses. This was what we see, embolization syndrome. And I know this happened because I put the iliac stents in and she came back with painful blue toes. And I said, I'm sorry that happened. This is either going to get better or it's not going to get better. And she said, what does that mean? I said, well, if it doesn't get better, you might lose toes, you might lose tissue. But we can't fix things inside the little digital arteries. That is the concept that we were taught how to think about. Now, in this patient, she came back to see me 3 months later and still complaining of pain in her foot, in her toes. We ordered an ultrasound. She had triphasic waveforms all the way down. She had a digital pressure of 70. That should be fine. And she complained of an intense fire-like pain, rubor, in those first 3 toes. And it sounded like rest pain to me. Now, before that point, patients teach us things. If you listen to them, they will teach us how to think about things. And before that, I always thought rest pain was the entire foot. It's major arteries. I didn't think it could be digital arteries. But she was describing rest pain in her first 3 toes. Pain was worse at night. So I said, okay, you convinced me, you're going to get an angiogram. This was her SFA, looked pretty normal. The popliteal looks good, 3 vessel coming down, all look pretty good. You can see the posterior tibial coming down to the bottom of the foot. You see the anterior tibial coming down to the dorsal pedal. You see digital arteries in her toes. I can see them, but she's still complaining of pain. When we looked at the different views, we realized that in her anterotibial artery in the right panel where the arrows are, the dorsal pedal artery was occluded in one of the segments. And it dawned on me that that's the reason why she's still having pain. And so we performed atherectomy, orbital atherectomy in that vessel, the single vessel down and back. And then when I did the angioplasty and then took a picture, you could see the toes light up at the bottom. And so this patient post-op was normal. She had blood flow in her toes from the posterior circulation before. She did not have the anterior circulation that connects. Now, most people have a connection between the anterior and posterior circulation. Her digital pressure was 108, and this is an example of someone where the connections happen from above and below. And because she didn't really have that, she had an isolated area of tissue that was not going to get better until we actually repaired that vessel. So she had an angiosome that was being fed by that one artery, and that was not going to improve until we actually fixed it. Okay, perfect. All right, can we jump back?
Yes.
All right, Will, you back?
Yeah. So this is what we did was we ran the laser through twice and cleared a fair amount of debris, and then we angioplasted it, which we put a balloon in, a 5 millimeter diameter balloon, cross Stella, which is made by Terumo. And this is our completion result. It's pretty good. The flow is brisk. You can tell it goes about the same time. But you see that weird haziness in the proximal portion of the superficial femoral artery. That's a dissection right there. And so I worry about this, that if we don't do something to that dissection, as soon as we leave the room, all our hard work will be for naught and it will drop down. So that's why in my hand I have what's called a Misago, which is a stent made by Terumo, which we're going to put into the artery itself to kind of prop open that dissection and restore true lumen, restore flow. So live? So it's a thumb wheel design. You kind of crack it down, and then I kind of play with it and make sure it's on the marks that I really want it to be at. And you can kind of really deploy it with really great accuracy. And then we're going to walk it down like that. And I like the way that's going. Yeah, go ahead. The thumb wheel deployment is this rapid exchange thumb wheel deployment is very popular in Japan. And that's where this stent was designed and was produced and things like that. So I like the way that stent. So the stent itself is made of a nickel titanium alloy called nitinol. And so when it comes in contact with warmth, like to the blood, it expands and dilates. And so it has inherent radial force, which essentially props it up against the vessel and props open the section.
So,
and so,
Will, on this case, how often do you have to stent for these cases like this?
Oh, with something this complex, this really extensive disease, I'll take a 7150. It's not uncommon at all. I mean, this patient has critical limb ischemia with rest pain and a long segment suprapubic femoral artery occlusion. It's not terribly uncommon at all for us to have to stent something like that. So that's okay. You know, we're trying to restore the natural flow of the body, and this is a good way to do it. You know, other ways you can treat something like this would be a bypass, right? But a bypass would be something where he'd be in the hospital for 3 or 4 days. He'd have a long couple big incisions. This is something we've managed to accomplish in, about 30 minutes. And he walks out of here in another hour after we're done with the procedure. So I think it's, modern technology is pretty fantastic.
Yeah, and there's a management strategy for a lot of these patients. He's in his 40s. He's a diabetic. He's going to be back. Vascular patients are
100%
are lifetime. It's a lifetime commitment both ways.
And so, Chris, to that, I think it's really important to highlight the maximal medical strategy that we place these patients on. So he's going to be on a maximum dose of the statin therapy, which is going to be really important for maintaining stent patency. And then we're also going to talk about, potentially antiplatelet. So he's going to be a lifelong antiplatelet use, definitely an aspirin. And in the immediate period, we're going to put him on probably Plavix as well. And then you want to talk about Xarelto potentially?
Sure. The other alternative in somebody that has polyvascular disease, someone that has mesenteric, carotid, leg disease, it may be a more aggressive approach to that therapy. And the trial it's called the COMPASS trial, where they gave us a trial with a true anticoagulant and then a true antiplatelet. As a vascular surgeon, I want to be able to stop clotting and stop that process. And we never had this before with Coumadin. Coumadin was always risk prohibitive. But with low-dose Xarelto 2.5 twice a day and aspirin 81 daily, that trial clearly showed that there was less death associated with MI, less stroke
Are you
issues,
on a Zoom?
and then less reason for me to have to fix them again. And so for our very complex patients, sometimes Xarelto and the aspirin therapy, as defined by the COMPASS trial, gives us real-world data on how to handle some of these patients.
100% agree. And so, I think it definitely is a consideration. This gentleman, he's so young. We've already fixed his other leg. That I think Xarelto would be a really good option for him. Strict blood pressure management, strict diabetes management. We've already gotten him to almost stop smoking, which is pretty awesome. And so all those things together are going to be really, really important. And that's all part of maximal medical therapy. And those are guidelines that are brought forth by the American College of Cardiology and the Society for Vascular Surgery together. because, these patients go hand in hand, the cardiac patients and the vascular patients. It's the same pathophysiology.
Excellent, Will.
So we're just ballooning. We're ballooning the stent open just a little bit right now, and then we're gonna be able to take a picture in just a second. Let you guys get on with that.
No,
Paul?
we appreciate how expeditious you were today. Normally you take a lot longer.
Yeah, I take a lot longer. Oof. My pride is destroyed. DSA. I was just slowed down by the team.
Yeah, look at
no, I couldn't do it here without the team here. I got Erica manning the ship and back, and Wendy handing me stuff, and Aaron is driving the C-arm. So it's a great team, and Will is providing the patient with bad jokes to put him to sleep. So it's really a great team. So anyway, I think it's a great result. The flow is extremely brisk down the leg. We did have to do 2 accesses, but that's okay. Sometimes we do have to do something like that. And we'll get him up and walking probably within an hour after we're done. You look here, this is kind of a good measurement of the restoration of flow. The flow is really brisk and profuse coming out of this tibial artery. The Slender technology has really revolutionized what we can do. I did the whole treatment essentially from the tibial artery. So pretty neat stuff.
So, Will, just real quick, how are you going to manage closure for this patient? We need to get him off the table. And
I'm going to use a device in the groin. For my groin access, I'm going to use something called an angioseal device, which is essentially where a plate goes on the bottom of the artery and on the top of the artery, and over time it dissolves and goes away. And then on the tibial access, I'm going to use something really complex called a 4x4 and a tegaderm and some tape. Tape provided by Will in the back. Wendy's actually going to manage the tibial access for me. So we're going to tape it down really tight and let him walk probably within an hour.
So it's not uncommon for patients. This is a very typical scenario for our day. We, somewhere about 6 of these in each of the rooms, so about 8 to 10 to 12 cases a day like this. So patients have to move through the system. We have a lot of PAD in this area, and so they'll be recovering in the recovery area for about an hour or so, getting up, moving, walking, making sure their medications are corrected, and then getting their follow-up in a week or so. So that's a very standard, fairly typical case that Dr. Harris made look very easy. So, Will, that was an excellent job. We're going to jump away.
Thanks, guys, very much, and I'll see you all later.
All right, excellent. So I could spend another hour talking because I have lots of pictures, but I think we've earned our 10 o'clock break. How about that? And as we come back, we'll go ahead and enjoy the remainder of any food that's out there, use the facilities. We'll be starting back around 10:30. With the aneurysmal disease segment. Tish Poe is going to be speaking, as well as Dr. Quazzo. So thank you for your attention.